Good evening, everybody. Dr. Manju, Dr. Aparna, you're going first, right? Do you want to check whether your audio, video, and screen share is working? Dr. Aparna?
Yes, ma'am, I'm here.
No, I need you to check whether your video and if you're going to use any slides, it's 8 o'clock. So just quickly check whether your slide share is working.
Yes, ma'am.
Vidya, let me introduce Dr. Babji, my
Yes,
mentor and Vice Chancellor of Andhra Medical University.
Namaste.
Hello.
Dr. Vidya is your classmate, no?
Yes.
Oh,
And
I
anesthesia.
remember her.
Everybody does.
Dr. Manju, do you want to check your slides or is it you're good to go? Awesome. Let me just check with Dr. Sanjeev. Dr. Sanjeev, if you're logged in with some other name, please.
No, madam. Good evening. I have logged in.
There. Yeah, thank you. You were right in front of me and I didn't see you. So, good evening, everybody, and welcome to today's episode of Marvelous Medicine, which is basically about using quality improvement tools in problem solving. Dr. Manju Puri needs no introduction to Marvelous Medicine because this is her third time. She's the Director Professor, Department of Obstetrics and Gynaecology at Lady Hardinge Medical College, Delhi. She did her MBBS and MD in Obs-Gynae from PGIMS, Rohtak. She's the President of the NARCHI Delhi branch, Subject Expert Committee, Central Drugs Standard Control Organization, member National AEFI and Signal Review Committees, and an External Quality Assessor in Public Health Facilities. She received the Honorary FRCOG, FOGSI Achiever Award, APJ Abdul Kalam Excellence Award, all in just last year. She has more than 175 publications to her credit and has edited 3 books. But mostly, she's extremely enthusiastic about quality improvement. And despite being so senior, she interacts very well with all the junior colleagues and is absolutely a pleasure to learn from. Welcome, Dr. Manju Puri. Joining her will be Dr. Aparna Sharma. She's a Professor of Obstetrics and Gynecology at AIIMS, New Delhi. She did her MBBS from IMS Banaras Hindu University, MD OBGY from Maulana Azad Medical College, and has done her Masters in Fetal Medicine from Barcelona University. Aparna is the Secretary, Society of Fetal Medicine, and Chairperson of the Multi-Pregnancy Committee, Stillbirth Society of India. She's also the co-convener of the Early Pregnancy SIG Indian Fertility Society. Aparna has several publications in international peer-reviewed journals and has received several FOGSI awards that will take too much time for me to list them. Dr. Aparna is, in tandem with Dr. Manju Puri, they have worked together on many projects and they have several publications which they have done together. So welcome, Dr. Aparna, to your second time on Marvelous Medicine. Last but not the least, we have Dr. Sanjeev Singh, who's the Medical Director, Amrita Institute of Medical Sciences, Faridabad. Dr. Sanjeev did his MBBS at SMS Medical College, Jaipur. He's a pediatrician by training and did his Masters in Hospital Management and PhD in Infection Prevention. He's also done fellowships in patient and health worker safety and health technology assessment. And he's also a fellow of the ISQA. He's a Shia ambassador, adjudged as Heroes of Infection Control by APIC, and the Best Infection Prevention Control Practices by Quality Council of India. He's a member of the National Task Force on Antimicrobial Resistance, technical advisor on IPC and AMR to State of Kerala, member of Technical Committee in NABH, and co-chair of Health Services Committee in FICCI. Thank you, Dr. Sanjeev Singh, for making time for Marvelous Medicine despite your busy schedule. Over to you, Dr. Manju.
Yeah, good evening to all. And I think I'll ask Aparna to start and then I'll take over. Aparna, over to you.
So a very good evening to all of you, and I'm happy to be here for the second time. First time we had discussed about respectful maternity care, and this time we are talking about something which is very close to our heart. Well, I'll start with the, I'll share my screen here. Sorry. Okay. I hope my slides are visible.
You just need to go. Yeah, perfect.
Right. So I'll begin by saying that I'm a clinician. I'm a maternal fetal medicine person, and I'm completely into high-risk obstetrics, and I work in the area of fetal therapy and fetal intervention. So when I talk about quality, and people actually find it very strange, and for clinicians, our take on quality is that quality is for managers to fix. And why should we even talk about quality? But the reality is, and the fact of the matter is, that the clinicians are the face of the healthcare. We are the ones who are handling patient interaction, and we face the consequences, and we are most affected by the patient outcome. And a lot of incidents do affect us directly, they do affect us indirectly, and we work in a government setup, and we face the grievances, whether we are directly involved, whether we are indirectly involved. We are there at the helm of the affairs. And problems like, early initiation of breastfeeding, no oxytocin being given to the mother, emergency OPD sick patients treatment getting delayed, delay in discharge of patients, all of them. I have done my surgery wonderfully. But at the end of the day, experience of the care is getting affected and the patient is not happy. Everything is coming back to me. Quality problems typically occur not because of failure of goodwill, knowledge, or effort devoted to healthcare, but because of the fundamental shortcomings in the way the care is organized. And trying harder will not really work because the systems have to change. And based on all of this, it all started some 8 years back when all the understanding really started, pouring in, that the quality of care, we really have to start by, assurance, quality improvement. And that is where the quality of care is really defined. And clinicians, whether we want it, whether we don't want it, we really have to start taking that leap towards quality, and we need to understand quality. And that is what it is, where the point of care of quality improvement really came about. And we adopted this model. And why we started talking about quality using this tool is that it was really a point of care tool where it came to us at a point where, we started by starting small, something which was in our hand, our field of influence. We have to change the system. But I will not start by saying that I will, end the maternal mortality in India. But I'll start something by saying that, I'll start by giving oxytocin to every mother. It has to have, the bottoms up approach where I'll start by saying, okay, what can I do? What can my team do? But of course, I need a supportive administration. I need to take the, the managerial team with me. And it is internally driven. And all of the people here are, people who are, some of them are in administration, some of them are senior clinicians, and all of them really understand that government is big on guidelines. Government is big on policies, but they don't work on the ground level. Why? Because the people on whom these guidelines are given are not internally driven. So when we talk about quality improvement, when a clinician talks to another clinician and says, look, this is the problem, why the system is not working, this gives a motivation to the other person that, okay, this is my problem, I will handle it. So internal motivation is something that really drives quality. And that is where we came out with this model of point of care quality improvement. It was a joint initiative by WHO and Collaborative Center of AIMS, newborn, and USAID assist. And this was a very simple 4-step approach to quality, where it started from identifying a problem, forming a team, writing an aim statement, analyzing, measuring quality of care, developing and testing changes, and sustaining the improvement. Just 4 steps approach. This has gone through multiple layers. So this is actually a model which has tested, stood the test of time over this last 8-10 years, almost 10 years now. So this is step 1, where you review the data, make a name statement. Step 2, where you analyze your problem. Step 3 is the PDSA, and step 4 is sustaining the change. How did it all start? It started in AIMS with our director, sir. Institute date was launched in 2015. Following it, we had our first batch MBBS training. We started with the undergraduate training for QI for the MBBS. This was our nurses training, where we sensitized with the nursing workshop, where we said, okay, nurses also need to be trained. Then slowly we started spreading, not just in AIMS, but 6 AIMS, other medical colleges, other state medical colleges, and other medical colleges faculty. Now from there, what all we did? QI in labor room. So how we started is that in 2018, we did not have the practice of birth companion in labor room. So we started a quality improvement initiative, and we established the practice of having birth companion in labor room by a systematic quality improvement approach. So this was a planned initiative where we took that in our own hospital. QI in the COVID pandemic, where we talked about how do we communicate with the relatives of the admitted patients, of the obstetric pregnant patients during the COVID. This was another quality improvement initiative. So we did various methods, utilized the quality improvement initiatives to establish this facility. Again, QI in a rural center of AIMS. Then this was a Ballabgarh initiative, where the system for checklist to aid young physicians to manage obstetric emergencies in a rural India. This was done by our intern. Varad is our intern who said, he attended our QI workshop, and he said, madam, our system in the rural area is so not organized. I want to use this method to implement this. So we did a detailed QI systematic initiative and established this thing. In our own department, we reduced the waiting time to initiate the infertility treatment in our own department, and improved the documentation in admitted antenatal care. Then again, we established for the first time, actually, a birth plan clinic in the antenatal clinic of AIMS in the Department of Obstetrics and Gynecology. Within our family planning unit, we established postnatal clinic using this established method of systematic quality improvement initiative. Now moving outside AIMS, and all of this, me and Manju Puri ma'am, we have done together to take this QI initiative out of country. Now, all of this happened since 2018. Now, we know that there is something called a Lakshya initiative in the country. We have to understand that the country has been trying to improve labor rooms. Our government has been trying to improve labor rooms. So there has been a lot of initiative, a lot of money has been put in to create infrastructure in the labor room. However, the processes around the labor have not really improved. So a part of the labor improvement process is to improve the labor experience of care, is to improve the processes around labor. And for that, there is something called the mentoring program implementation for Lakshya in medical colleges. So for that initiative, it was to improve the capacity of state medical colleges, and we built a pool of QI coaches across country. So we did QI coaching for 52 medical colleges, and within that, after that, we did the coaching we built up mentors of around 20 to 35 mentors, and then we did coaching of 10 medical colleges to enable them to get certified for Lakshya. So this was one of the medical colleges that we visited and did rapid improvement cycle using the POCI methodology. So the crux of the matter is that the POCI methodology for quality improvement is something which we have tested for a busy clinician. See, important thing is that quality, when we talk about quality to any clinician, there is so much of resistance to accept it. But the 4-step approach to quality improvement is a problem-solving method which talks us that we have to break the problem into bite-sized pieces, take a systematic approach to quality improvement, and then try to solve it by an initiation at the level of the clinician. There are various resources. This is the point of care quality improvement website, which is hosted by AIMS and WHO Collaborating Center in association with the WHO India. So this is the point of care quality improvement website, where you have the point of care guide, which is the learner's guide and the facilitator's guide. So there are various learning resources. So this is the learner's manual and the coaching manual, where you have all the PowerPoint presentations. Then there's a QI project template, which is available, which can guide you to make projects. So this website is a comprehensive resource material which is available to make manuals, webinars, posters, and various activity logs on what is really happening. I would just like to end by saying, so what I've done is really give you just an overview of the work that has happened with quality improvement. Dr. Manju Puri would talk in detail about the various projects, but quality improvement has to become a way of life in the way that we are currently working. Success stories, the cases that I have shared, may just be the tip of the iceberg, but we have to keep trying. If I say I am a clinician and I am not concerned about quality, that is not going to merit any longer. We have to understand that as clinicians, we need to take up quality, and it is possible to take quality. And quality improvement is complementary to quality assurance. Quality assurance, of course, I need infrastructure. I need water, I need soap to wash my hands. But if I am not motivated to wash hands, nobody on this earth can make me wash hands. QI can be done within the existing resources, but measurement is essential. Teamwork is the key, and sustenance often needs system approach. And demystifying QI is crucial for frontline health workers for uptake and spread in hospitals. Doing quality improvement is like repairing a bicycle while riding it. It is tough. We cannot get off, and we cannot improve the system without learning QI. So I think it is absolutely essential for all of us to understand what is QI and implement in our day-to-day life. And I would just like to end by saying that me and Manju Puri ma'am have been on this wonderful journey together for the last 10 years, and we do hope that we'll continue to do working together, do some good work in the future also. Thank you very much.
So thank you, Aparna, for laying the foundation. And thank you, Dr. Vidya, for having me here to speak and share my journey of quality improvement. It is indeed a pleasure to be on this platform. So I'll share my screen and I will take it forward from Aparna. Yeah, I hope my screen is visible. Is it visible?
Yes, ma'am.
Right.
It's clear.
All right. So basically, I was introduced to quality improvement by Aparna, and that was in 2018. So I'm about 5 years old in this journey. And what I can say is that it has made a lot of influence as far as our work experience and making some changes is concerned. I don't say it is very easy, but it is definitely not impossible, and it is absolutely doable. So, if we look at, we as healthcare providers, we all believe that we work hard, and we actually work hard, and we are doing our best for our clients and patients as per whatever facilities are available at our workplace. But we need to pause and think that, is this our best? Is there any scope of improving upon the care we are providing within the given resources? Are we providing evidence-based care? Are we unknowingly doing any harm? can we improve the experience of care of our patients and their relatives? And to top it all, we often feel that people just don't listen to us. What do? We keep telling them, they don't do it. So it doesn't matter how many resources you have. If you don't know how to use them, it will never be enough. So simply ensuring coexistence of infrastructure, medical supplies, healthcare providers, and guidelines does not lead to optimal healthcare. We need to use it intelligently. So the way forward is that what can we do differently in the given resources? We know that resources may not be adequate, especially in public facilities where we work. But then, we can't be waiting for the resources to be replenished and only then improve upon. So we can start working on what we can do. And this is what Aparna has said. These are beautiful modules and which you all can go through and generate your own certificates as well. So quality improvement is a management approach, which is the healthcare workers can use to reorganize patient care within the existing resources to ensure provision of quality care to their patients. So we do whatever is possible within our own area of influence, and we do that. So it is not a fault-finding exercise, but a problem-solving approach. So we all know this model of WHO quality of care, and we know that provision of care and experience of care are two very important things. And these are the processes of care where we can work and within our given resources and make a difference. So something like observing evidence-based practices in routine care, actionable information systems, functional referral systems, effective communication, respect and dignity, and emotional support. All of these may not be within our reach, but whatever is within our reach, we can definitely look at it. And of course, you need competent and motivated human resources and essential physical resources. All these are required. These are absolute, essential ingredients for providing quality of care. But out of all these, we will focus on things which we can do ourselves. So these are the four steps which Aparna had highlighted. So I'll take you through these steps one by one by walking you through one of my projects. So listening the problems in our hospital, which is a public hospital, there are a whole lot of problems. There's crowding in the OPD, toilets are not clean, there is a poor referral system. The relatives of hospital employees break the queues. Pregnant women admitted in labor room, even if they are booked with us, 45% were anemic, more than 50% are anemic. There's irrational use of antibiotics. There's shortage of beds in the labor room. There are very high cesarean section rates, and there were high rates of preventable stillbirths at our facility. So these are some of the problems which I have listed. So just to help you decide. So, then we need to prioritize. I can't solve all these problems in one go, and neither are they within my reach. So I divide them depending upon the effort which is required to solve it and what value do they have in the patient care. So if I look at here, so the do now ones would be low effort and high value issues. So irrational use of antibiotics has a very high value for patients' benefit. A high preventable intrapartum stillbirths, that is something which we need to tackle, and high cesarean section rates. So these would require a lower effort because it is all within our practice and our processes. What would be there to do next? So book pregnant women who were admitted in labor room with anemia, and to say because they are coming to us regularly, so we can work on that. So that was on my next to-do list. Then on my do later list, it was relatives of hospital staff, they were breaking queues. Although this required lower effort, but it had low value as far as patient care was concerned. So I parked it for do later. And then don't do our poor referral system. I'm to say we have low risk, high risk patients walking in because it is not within my reach. So I decide not to touch upon it. And overcrowding of the OPD. So, I thought, let me just leave it at that. And because it requires a lot of high effort and a lot of administrative inputs. So I'll share my journey of irrational use of antibiotics. So this is, I thought it was simple and easy to fix. It was important for patient outcomes. It did not need new resources. It had a short turnaround time. So the step one is that I needed to select my team. So I looked for volunteers who were enthusiastic, those who wanted to make a change. There's no point having those who are already saying we can't, there nothing can be done, the system is very poor. So you pick up, you do get some who are enthusiastic, those who are involved. So those who are already doing the work that needs to be changed, it would mean the residents, consultants, and the nursing officers. We also need some people who are influential, to whom other people are going to listen and they can get the things done. We need to include people from all levels, from administrators to the support staff. So all this was required. And so in this team, we had a senior consultant who was the advisor. Then we had a junior consultant, the resident who was the communicator, and the nursing officer who was the recorder. So then writing an aim statement. So we need to, because a team has many members and ideally between 4 and 9. So we need to have an aim statement so that everyone knows what we are going to do. So the characteristics of a good aim statement should include what are we improving, who will be affected, how much do we need to, how much are we going to improve, and by which time is the goal to be achieved. So our problem here was all patients undergoing elective surgery were receiving antibiotics for 7 to 10 days. Anything and everything was being given. And so in my aim statement, we decided that we were going to focus on low-risk patients undergoing elective surgery and give them a single shot of antibiotic, which is evidence-based prophylaxis within 30 minutes of the incision. And we decided to, from the baseline of 0, we thought, let's bring it to 60%. There's no point having 100% because you may not be able to reach and going to fail. So from 60 to 100 could be your next aim statement and next project. And I decided to do within 8 weeks. So my aim statement was we aim to increase the single shot antibiotic injection cefuroxime within 30 minutes before incision in low-risk patients undergoing elective surgery from 0 to 60% in 8 weeks starting 14th March. Say, I've just given you an example. So my second step was analyzing the problem and developing indicators to measure progress in reaching our aim. Because if you don't measure anything, you cannot make any improvement unless you measure it. So basically, we needed to go into a detailed analysis of why is it that, although it is said, it is evidence-based, that single shot should be given, why are we unnecessarily giving so much of antibiotics? So we analyzed the, the whole problem. So there are various tools of analysis. Because of paucity of time, I would not be able to go into the details, just give you a few examples related to the project. So we did a fishbone analysis. So this means, we look at the width, of all the contributory factors. So factors related to policy was there was no departmental antibiotic policy in place. Those related to people was lack of sensitization, lack of confidence in aseptic practices. Everyone was worried about post-operative sepsis. Then as regards the place, there was non-availability of antibiotics in the OT. And then also, as regards the procedure, who would administer, where would be, when would it be administered, where would it be documented? So all those things were the issues which came up with the help of the team. If we look at the, 5 whys is another tool, which is also a good tool, which allows you to go into the depth. So fishbone analysis takes you to the width and horizontally, and this is more deep. Say, the example is that some patients are not getting prophylactic antibiotic when we rolled out this policy. So we try to understand why are they not getting prophylactic antibiotics. So antibiotic was not always available in OT. That was the answer. So we asked, why is it not available in the OT? Because it is out of stock in the main store. So why is it out of stock? Because it takes 1 month to receive the supply before after it is ordered. So again, another why doesn't the storekeeper place the order in time? Because the OT sister does not inform, she informs him only when a stock is exhausted. So why does the sister not inform him in time? Because she does not keep a buffer stock. So the problem got sorted that she would keep a buffer stock. Then next point was we had to develop the indicator. So we develop one indicator of process, the action that was taken for delivery of care. That was administration of single shot antibiotic. And the second was measure of outcome. That was the result of the actions taken. That was the incidence of surgical site infection in patients receiving single shot antibiotic. It is important to have outcome measures very clearly, pointed, because we need to track them. So you must make sure that what would be the numerator, what would be the denominator, what would be the frequency of data collection, what would be the data source, and who would collect it. So all this has to be absolutely clear. So this is the way we would plot our indicators. So you can see this orange line going up. So that is the proportion of percentage of patients who were undergoing elective surgery and receiving single shot antibiotics. So say we started this project in July 17. So we started from 0, it went slowly up, and it went up like this. And the lower line shows you the number of surgical site in percentage of patients who would have surgical site infection of all those who received single shot antibiotic. So this was here, and we had the months plotted here. So you can see that this project is still ongoing. It is about, almost 6 years old now. So the next step is developing and testing changes, the PDSA cycle. So what can be the changes? So changes can be related to improvement of knowledge or skills, to eliminate waste steps, to reassign tasks and duties, to reorganize tasks, okay, and the place where a particular tasks are performed, to improve patient relationship and reduce variation. So, these are in broad the categories of change. So when the team gets together, they put the problems on one side and they list out the solutions on the other side. So this is how we would decide that these are the problems and these are the possible solutions. There was no antibiotic policy, so we decided to prepare a departmental antibiotic policy. There was lack of awareness of AMR amongst the consultants and residents, so we decided to hold a sensitization and consensus meeting. Lack of confidence in asepsis, so we conducted a workshop for residents and nurses on asepsis. There was reluctance by some to implement, so we started small. So, in my unit, I started, and then I shared my data with them, and then the others got motivated. Non-availability of antibiotic in OT, we identified a nursing officer to facilitate that. So this is broadly. These are not all the, change ideas which we implemented, but these are broadly. So what is a PDSA? This is a plan, do, see, act cycle. So here, I'm just giving you an example of the first PDSA we did. So the plan was to prepare a departmental antibiotic policy. So who will prepare the policy? We decided Dr. X will prepare the initial draft. So, and then it would be discussed, right? Then where will it be prepared? So it was Department of Obs and Gynae who are going to prepare. When will it be, when will it be ready? So we decided that it would be ready by next week. And how long would be the duration of PDSA? We put it as 2 weeks because once the first draft was ready, we had to generate a consensus, right? So the first, the presentation in front of the department would be latest by 2 weeks. That is what was decided. And how will we know that it has been prepared? So the Dr. X had to schedule a consensus meeting. So that was the end point of our PDSA. So what do we expect from this action? That is the final answer to this. So this is how the PDSA is done. So we plan the change, we test the change, and then we study what did you learn, and then the next steps as per the results of the test. So once we get the results, say for example, they presented the antibiotic policy, many people raised objections. So we then thought that we need to adapt it. So we changed we addressed the objections and then we moved on further. So that means after every study, you can decide to adopt, adapt, or abandon the cycle. So these are a few, the PDSA changes. So formulation of antibiotic policy, detailed discussion, finalization after agreement, sensitization workshop of residents, and rollout in the department. So all this took approximately a month, 2 months rather. And so we built a consensus of all involved. Not everyone was convinced due to fear of asepsis. So all the workshops were done. So we adapted and we started small. The next was we implemented in one unit because others were not ready. They were scared. So it was easy because we had motivated people there. And we also collected the baseline data on the outcome, that is surgical site infection in the meanwhile. And ultimately the use was, because one unit was using, it was 35.6%. And so we shared our experience with others, presented the data, and they also agreed to it. And we also showed them there was no increase in surgical site infection in those who were receiving single shot. Then it was implemented in the whole unit, and it went up to 50%. Okay. Then we identified a coordinator and nodal officers in each unit with monthly meeting in person with presentation of data and discussion of cases where, unnecessary antibiotics were contributed. It increased to more than 60%, and that was our aim, which we had to. So we learned that the increase in accountability and ownership pace, so we adopted that. So it remained okay for next 2 months, and then again it went down. So we thought that we need some hard wiring. So then we started, adding induction training of residents on regular sharing of data by nodal officers with coordinator. So we learned that wide dissemination and need for continuous follow-up is important for sustenance. And then we started holding, next year it stayed at 80-90%. And one of the meetings were missed with the coordinator, and then again the rates came down. So we fixed a day of the month where all the nodal officers will get together and review the data, and also have a WhatsApp group. So we learned that for a change to sustain, it should not be person-centric but self-sustaining. Then we started sharing the data monthly. In our monthly statistical meeting, we'll show a bar chart, and it would show us the usage rate and also the surgical site rate, and we are following it till date. And the lesson we learned, with this PDSA was that need for continuous follow-up and sustenance and sharing of data keeps the momentum of the change and everyone interested. So this is just in a short about what we did to implement this basic change. And imagine now about 90% of our patients are receiving single shot antibiotic. And this was the paper which was published in BMJ Open Quality. And during COVID time, we had stopped, and then again we picked up. And you can see the surgical site infection. Blue is with those who get multiple drugs, and this is those who get single shot. And you can see that added advantage was that even in those who were getting multiple drug, the rate of sepsis reduced because people were now taking more aseptic precautions. And this paper was also awarded. So what was the, what we did to sustain the improvement was continuous monitoring of process and outcome indicator monthly, sharing the data, generation of competition amongst units, and appreciation of those doing well. So this is how we would put it in our monthly meeting. So there is no one giant step that does it. It is a whole lot of little steps, but it does work. So after that, we have done a number of cases. So this was during the COVID time. We wanted to, do maternal neonatal bonding. That was absolutely, haywire. So it was done with quality improvement, and we published it. Then optimizing transfer of post-cesarean patients to post-operative ward. Because ours is a very heavy hospital and the beds were limited. So patients were lying on the trolley after cesarean, even for 2 hours, 3 hours. Everyone used to kind of fire everyone around that, why is it? Then we took it as a quality improvement project, and we were able to shift 100% patients within 10 minutes of arrival into the post-operative ward. Then, in the family planning, we improved the rates of postpartum IUCD insertion. And then initiation of breastfeeding in 1 hour of cesarean delivery in LHMC. Different people took up different leads, and you can see different people here who are participating, and it is a joint effort. It really builds up the team and the bonding between people who work. This is our ongoing project, and a very ambitious project, which is reducing anemia in our booked pregnant mothers, a QI initiative. So see, from 45%, we have come down here less than 20%. So we have about 10-15%. And of this 40%, about 70% were moderate anemia. And of the 10-15% which we have now are all mild, between 10 and 11 gram%. And the same project we are going to, this is a single unit work. We are going to roll it out in other units and also in other hospitals of Delhi. Another important thing which came up was power of daily huddles in COVID-19 pandemic. And this was just a brief meeting in the morning for about half an hour. When I was the head of the department, I used to take. And all the problems were kind of settled during this time. And we found it very, very useful. And then we started with OPD huddles. And our paper on daily huddles in antenatal clinic, an effective tool to optimize antenatal care, has been accepted for publication yesterday only. So it is just the whole group gets together. So we come to know what drug is not available, what papers are not available, what practices are wrong. So everyone would kind of contribute what they are going to do to make the patient experience better. So we have interns, we have everyone here, the nursing officers, the guards, everyone is there. So quality is everyone's responsibility. And the teams of obstetrician, we have trained teams of obstetricians, pediatricians, anesthetists, nursing officers, and officers from administration in different hospitals of the Delhi. We have also done capacity building in the medical colleges for Lakshya. Aparna has already shared it with you. A capacity building even for Ashas and ANMs we have done. So quality is never an accident. It is always a result of high intention, sincere effort, intelligent direction, and skillful execution. It represents the wise choice of many alternatives. Because in your team, you have everyone there. So it is kind of belongingness. So if you are successful, then everyone kind of celebrates that success. It is not that me who is doing it, it is everyone who are doing it. So practice the philosophy of continuous improvement, get a little bit better every single day. So nothing is impossible. I would end with that. The word itself says I am possible, and a small group of determined and like-minded people can change the course of history. And I believe that as clinicians, we should not now say that this is not possible. We have a tool which we can, use and improve the care, clinical care and the experience of care in our patients. Thank you so much.
Thank you so much, Dr. Aparna. Over to you, Dr. Sanjeev.
Right. Thanks, Dr. Aparna, and thanks, Dr. Manju. The whole journey of your 10 years and 5 years of Dr. Manju, fantastic work. It was very divine listening, spiritual experience. I think the whole comprehensive way that you have handled the whole quality initiative is really remarkable, and that too in a resource limitation with the involvement of so much of the other stakeholders is something which is really phenomenal. So very, very congratulations. It was a real pleasure listening to both of you. And the both of you are so passionate. The way you speak, it is very contagious. It's very infectious. And it looks that you sort of live this whole thing on a daily basis, and it's not been forced on you. And the word which Dr. Aparna used, internally driven, and very reflective in your presentation. So before I open up, just wanted to understand, you mentioned about identifying a problem, and then Dr. Manju did mention about putting that as a priority matrix. So how difficult it is to get the team together just to identify, because whenever we say, most of them say, tell us what to do and we'll do.
So thank you so much. Basically, I think it is not difficult to identify problems. It is what we see in our day-to-day experience. So it is not that you have to, for example, when I started with the antenatal huddles, so every time, the antenatal card had all the columns, no one would fill them. Is it right? So every time something which you are trying to correct, every day is something which can be picked up. That is what is my take on that. So it is your routine, small things which you can pick up. So that is what, I would do at this stage. I just gave that example that in case you have many problems, then how do you pick up the one which you would work on. So I think it is better to start with smaller projects. My first project was that transfer of patients onto trolley, because that was something which was a very simple thing. So that is what we worked. But antibiotic one was a bigger issue. So that took us quite a bit of time to convince people and get people on board. So that is my take. Aparna, you want to come on?
Yes, ma'am, I completely agree. I think the most important thing is that, it has to be the people who are troubled. The problem has to be identified by the people. The simple thing like, I say, the people are inside the labor room, they say nobody is telling us what is happening. So if I want to say a simple thing like, effective communication in the labor room, it has to be done by the people who are in the labor room. So if a problem is identified by the people who are facing it, the solutions will come from them. So then the making the team will not be a problem, because if I find a solution, then they will be the ones who are benefited from it. So this is why we say it is a bottoms up approach. The support that we get from the top is just facilitatory. We are not taking orders from the top. We are taking help from the top. And that is the difference when the quality is driven from the clinicians.
Fantastic. I think each word both of you utter is so touching. I need to have you, our hospital is very close by, so please drop us some time. It is so important to have such a clinician as a quality advocate. Uh, my next question before I open up is, public hospital has resource limitation. And everybody will crib, and there is a complaining attitude which every hospital has. They love complaining and saying that this cannot be done. So within this resource limitation, how do you sort of manage? And second is, if there are defaulters, what trick, magic you have applied to get to these defaulters?
So basically, if you ask me, I'm to say what happens is that that is why we said when you make the team, you must have someone who is influential as well, right? So the mix of the team is such that all those who are involved are on board. And for example, if I say I do not have iron tablets in the OPD, so I will have the store officer also on board. Right, so everyone is on board. So basically, it is lack of communication among people which is creating, problems. So once you have a combined meeting, then things do get sorted. So even in antibiotics, we still have people who would say because the surgery was prolonged, so that is why we gave antibiotics. So we would not, tell them that why did you give. So when we discuss it, so we just ask them, very politely that could we have given another shot. Right? And even if the dissection was more, it does not mean that the infection organisms have got entry into the abdomen. So this is how, they slowly and steadily, it kind of moves. Right? Aparna, over to you.
I think, sir, this is, the crux of the matter. So whenever we do any QI workshop and we have, say, 100 people, so there would be like, early responders, 30% who are like brimming with enthusiasm, like me and Dr. Manju Puri, who are like, ready to jump in and do something new. The next 20% of the people would be the lot who are like not ready to take action, but they are like okay to be the followers. The next 30% would be like जो कर रहे हैं, the people who are doing, let them fail. If they succeed, we will do it. That's the 30% of the lot. But the last 20% are the people who will not do it. Whatever you do, they will not change. Our principle is don't even touch that 20%. Don't waste your time on them. So focus on that 80%, and you will always find the top 50% of the people. There are people, and we believe in goodness of people. Over these 10 years, we have seen that there are people who are good. There are people who want to do good. And motivation of everybody is different. Somebody wants to be acknowledged. Somebody wants publications. Somebody just wants a label that, okay, you are the worker of the month. You just have to find that motivation in everybody and see what works. In a public system, there is no money, but still everybody has a different motivation to work. Just saying that, okay, you've done such a good work, will make somebody's day. And I think that is what makes it important.
I can see halo behind both of you. It's such a fantastic satsang that you're identifying goodness and you're transmitting goodness. It is so very well conceived and presented. Lata has almost similar question. How do you make people understand? I think it's very relevant to use hospital resources very judiciously when everything is free in your setup. Like they can really prescribe all the antibiotics on earth. So why just cefuroxime?
No, it is not basically, we go by whatever is evidence-based and whichever is safer for the patient. So whatever we have in the literature and whatever is available in the hospital, we kind of select based on that. And, it is not, if you do a thing and show it to people, their concern was only they are not confident that the surgical site infection would stay low. So, so once you are doing the process measure and you are doing the outcome measure, so they would not switch over to higher antibiotics. So that is how it is. So basically, it is a very slow procedure. If you say that, you can, the people can use whatever resources are available, they do misuse. So QI has to be done, say, supposing in the OT, you have a bowl full of, betadine, they just pour it and then the rest is discarded. So there could be a QI done on that. So it is a small thing that how many bottles are they using and, can we make a difference? So it is kind of making them understand. So you can't change it in one go, but I think gradually, slowly, things do make a lot of change and you make the sister the in charge. The one who's the circulating, she will be the leader of the QI. And then imagine how much of happiness she would get that she's put this thing in order and she gets a publication out of it. Thank
Fantastic.
you.
So,
Lata, you want to say something?
Yeah, Vidya, I want to say thanks, ma'am. Dr. Manju, I'm Lata here. And Aparna, great talk as usual. Ma'am, what you said is very true. I try to make a difference, but like very small things like, it's sometimes shameful to even tell that people don't even, the kind of attitude, I don't know what is the problem. Like simple things like using gloves as a tourniquet, syringes, each for same patient, because something is available free of cost in a hospital, people do misuse. How do you think we can bring down such misuse? That's what I'm talking. That is also part of quality, right?
Dr. Lata, really, I think the answer to your question is the next question, actually.
Yes.
Choose your battles. Choose your battles, truly. I'm
I
not
do
going
that.
to reduce maternal mortality on my own, honestly. And I think this is a big question. This is a generational issue. The kind of,
Yes.
as generations go on, the concept of rationalization. I do a cesarean section with 1 vicryl. The
Exactly.
next generation would be using 3 vicryls. Right. So I think there are some things we can change, some things we cannot change. And QI is not like, it is not
Changes
a
everything.
panacea for everything. So that is the first thing, is prioritize what you can do, what you cannot do. QA, quality assurance, is first. You need to have resources. Within the resources, what you can do, you choose. So I agree with you and I sympathize with you because we work in the same settings.
Yes.
And I completely understand the pain. But definitely we have to choose our battles. And we can't fight. And of course, I think most importantly for me, ma'am, and I think Dr. Manju Puri would agree, is role modeling. Whatever I do, I think 10 people are seeing me. And if I make an issue out of it, that don't waste this, at least one person will improve. And I think beyond that, maybe, whatever SOPs we are making, some difference I'm going to make, but, I think that is somewhere we have to draw a line.
Dr.
Yeah,
Lata, I have a
yes, ma'am.
suggestion.
Yes, ma'am.
The huddles make a lot of difference. If you do a huddle in the morning, say they repeat the same thing over and over again. For example, I'm giving you that example, say maybe OT morning huddle can be there. We can have the sisters and we can tell them they're going to pour little betadine in that, let it not be wasted. So, if you just recall that, it's kind of repeating the same thing over and over again, and it does make a lot of difference. It does.
I do that.
Yeah. No, that's wonderful. And we should not lose heart. I'm to say it is possible. Yeah.
Yeah, Dr. Ajay Sharma, you have your hand up. Dr. Ajay Sharma?
Yes, madam.
Yeah.
If you can switch on the video, can I switch on my video there?
Yeah, everyone,
Yeah.
anyone can switch on their video.
Oh, my God. Oh, yeah, I can see that. Yeah. Really, it is very, very impressive. Not just impressive, it is very inspiring, actually. And I would say that, the mediocre teacher tells, and good teachers, they explain, and great teachers inspire. And I'm really very much inspired the way Professor Aparna Sharma and Professor Puri have really explained all this. And really, it is coming from experience. I really like the contents, not just the contents, but also the way you are saying it from your experience about building the technical and non-technical skills. So we have been involved in training the gynecology fellows there. I'm a general surgeon, mainly a transplant surgeon. And in UK, care of critically ill surgical patient is compulsory for all the surgical trainees. And as since 2014, it is compulsory for the Gynae Onc fellows there. And we have been really very key to developing that. And on the similar pattern, Professor M.C. Mishra, where Professor Aparna Sharma works, he commissioned this acute critical care course, and we have really conducted 66 of those. Many of them, first 7 of them in AIMS, and then moving out to the rest of the nation, and most recent being at AFMC. What I'm trying to say here is that the maternal mortality rate still remains so high, almost 100 per 100,000, which is almost 10 times that of UK maternal mortality rate, and 20 times that of something in Qatar or in the Middle East. And I'll just quote something which you're already doing it. I'm not saying anything new, and you know far better than I do. My only limited experience of bit of contribution to gynae patient is when I go to Jan Swasthya Sahayog in central India, where I just like to read because I'm very keen to learn. So what I'm trying to say here is that, I would like to quote the Brace, the mothers, babies, reducing risk through audits and confidential inquiry in UK. And what we are really implementing, building the teams. One of the senior clinicians takes the helicopter view of whenever there is a problem there, identifying whenever there is a massive hemorrhage there in a department because of obstetric causes. And as soon as that happens, it is not that we do not know what to do, but it's a failure to recognize, and failure not because the registrars or the juniors or younger consultants, they leave hostel or home, that the patients really are not really looked after. It's just there's a lack of training there. And it is amazing what your departments are really getting the training. We always say that our colleagues, younger colleagues, they do not what we tell them, they do what we do. So that's how you are really inspiring. It is really amazing to listen to both of you. I would just like to say that, when we are talking about maternal mortality, almost 50% of them are due to non-obstetric causes. So hence, there is a key role for involving other teams. It could be, we don't have enough time to really expand onto that. But what I'm trying to say is that the training, it is so crucial. What I like to do is when I come next time to India, I keep coming 3-4 times a day. Sorry, not a day, 4 times a year. And, you might really place me through, Amle Seth, who is the HOD of urology in AIMS. I'm his batchmate. And this Dr. Sandeep Singh, you might know Hemant Sharma, who works in Liverpool. I'm his colleague there. And with the LHMC team, I work with Gyan Saurabh and Manoj Endle, the professor of the surgery. So what I'm trying to say is that next time I'm there, we would like to really share and most importantly join hands as how we can really contribute to technical and non-technical skills of our younger colleagues, let's say in gynae or in any other surgical specialty, most of the surgeons are not really good in identifying physiological deterioration of the patients. And it's just because just the way our education and training has been, really, it has evolved. It's just that we need to really develop these courses and help them
Yes.
to really develop these skills. So
Like
I won't
Dr.
really,
Ajay
I will shut
Sharma,
up here.
maybe we should, today let's stick on to the topic of QI. If you have
Yeah,
any comments directly on that, that's fine.
yeah,
We all
QI,
understand that training is part
yeah,
of QI, but there's a whole lot more
yeah.
than training, right? Training alone doesn't seem to cause enough change. That's what the whole story goes. So if you have any additional comments on today's talk, please go ahead. Otherwise, we'll go to the next question on the
Yeah.
chat.
Quality improvement through inspiration. I must admire you all. Yeah.
Yeah, thank you for that comment. Dr. Venkatesh Natarajan has said, how do you choose problems that are doable and those that can't be done? In other words, how to choose your battle. So, Dr. Manju Puri, if you can just spend a little more time on that slide you had of how you decide what to do and what. And Dr. Venkatesh, if you had something else in mind, then please unmute yourself and speak. Dr. Manju will try and get that slide back so that she can give an answer to that question.
I will get the slide here.
So meanwhile, Dr. Sanjeev or
Yeah, meanwhile, I would, Dr. Aparna, I would like to understand, like Dr. Ajay was mentioning about training, how do you change behavior? Because you have been training, but is behavior also changing?
So I think that is something very difficult, and like we said, but I think when we have seen, what we have really seen is that we should not be expecting very drastic changes in behavior. But when we actually do QI and we say, okay, let us take up one single problem and see how it is impacting the immediate problem that you are having. So suppose what we previously talked on this thing is respectful maternity care. When we have brought forward this problem and we talked about it, we do see that there is some subtle change. So I'm not claiming that you can change the world or the behavior from very internally, but I think it is, over the years we have seen that it is possible to be a little more optimistic about things, be a little more positive that you can do this thing within your means, and not just complain that unless you give me resources, unless you give me infrastructure, I am not going to do anything. That is how people behave towards healthcare. I do not have enough staff, I do not have enough money, I will not do this. But within quality improvement, what we try to say is that, okay, we don't have this, but we have this, so what can we do about this? So that kind of a behavior change is what we are looking, and we have seen this happen. So we start with what we have and what we can do with what we have. So I think that is what we are talking about.
Perfect. Over to you, Dr. Manju.
Yeah. So basically, when we talk about which problem to handle, so this is an example which I gave you. And we look at how much effort is required to solve that problem, and how much value does it have as far as the patient outcome is concerned. So when I looked at these, problems in our place, so irrational use of antibiotic was the one. Second was preventable intrapartum stillbirths. So those patients who were coming to the labor room and having stillbirths there. And then high cesarean section rates. Now, there's nothing to do with the resources as far as any of these things are concerned. Right? So they were only practices. But each one of these had so much of value as far as the patient outcome was concerned. So then if we look at here, relatives of patients, hospital staff, breaking the queues. Now, this, of course, it requires low effort and low value. Low effort, it is also of low value as far as the patient outcome is concerned. Not as important as would be antimicrobial resistance or stillbirths and other things. So that means you can leave these things aside and maybe can be taken up, because we should put our energies on something which is going to have a high value. And if I look at the referral system, patients, all kinds of patients would come. This is just not within my reach, and it does affect the patient care. I'm not saying, but it requires so much of, effort and it is, patients are coming from all over Delhi, so you can't have it. And so is true about overcrowding in the OPD. So even if there's overcrowding in the OPD, patients are put to inconvenience, but, outcomes are not as much affected. So this is how we would, kind of look at things. And then if you really ask me, something which is irritating the people the most is something which can be solved very fast. Because once you solve it, that would make a change in their behavior because they feel things have become so much more easier now. So I think that is what is the motivating factor. I hope I've made some sense. Thank you.
Extremely wonderful talk, madam. And the prioritization matrix is what I wanted to emphasize again. That's why I put it across, and you have made it crystal clear. Thank you so much.
If you have any other comments, Dr. Venkatesh, please go ahead. Any experience you would like to share in QI or any outcomes that you've had by using QI tools, please go ahead.
We tried huddle in our center for improving catheter-related bacteremia rates, madam, once. So we involved all the stakeholders. But the biggest challenge that we had is the most important members were supposed to be present for the huddle were consistently defaulting and they were missing. And that was a challenge that we couldn't kind of overcome. And as madam pointed out, then we decided that we will not think it big, but we made it very small. So we started with 1 unit and we tried to produce good results so that other people will also catch on. But that is one thing which was pertinent, I think. Behavioral changes, inducing behavioral changes in others in a very positive way seems to be the biggest challenge. And if both the speakers could dwell a little bit more on that, that would be very nice.
So I do agree with what you say. It is that is the biggest challenge. Like Aparna had explained, there are some people who are just not on board. So we don't touch upon them. So basically, initially you would pick up people who are kind of under your influence also. If I am my unit head, I am the unit head, then, I have some people whom I know who would listen to me and I can make sense to them. So initially we start with an enthusiastic crowd, but then, once you have the thing get sorted, you are kind of giving credit to the people who are around, the others do feel a little left out and then they come on board. So, that is what is my take on that. And you being a role model, you are not showing them down. You are just allowing them to absorb what is happening. And once, publication is something which makes a lot of difference when you look at the residents and the consultants. You tell them it is a very easy way. Within 3 months, you can get a publication. And your problem will also get sorted out. So when you talked about, that those people were missing from the huddle, then a QI on why are they missing, why are they missing the huddle would be another thing to solve. So, it can be as small as that. So, I give them I make that person the in charge that you are the person. Now let's look up why are people not coming for the huddle, no? So then we go on that. So it is very, very small things, but it gives you a lot of happiness and pleasure once you are able to overcome that. I think that is the thing which I personally feel. Aparna, you want to add something?
No, ma'am, I think that is the same thing. And I feel that QI is actually a culture. And there is actually you say that there is a time when there is a time for an idea. And you know that the time for QI is now. So there is actually a wave of QI. There was a time some years back when everybody would oppose it. And now it seems everybody wants to do it. So, and when there is that wave, everybody would actually get interested. Okay, what is this? So when it is like a problem solving approach, it is interesting. It actually empowers people. It says, okay, let's not just crib and see what we can do about it. So when people start seeing, even those who are very negative about it in the first place, kya QI karte rehte hain, then they will eventually fall into line and say ki chalo acha hum bhi karke dekh lete hain. So I think this is how slowly things will change. We don't really expect that, suddenly things will be all right. And even now people will be, apprehensive ki ye kya ho raha hai, why people don't like change. This is the fact of the matter. Nobody likes change. But the most important thing is, and what we've really learned is, whatever you want to do, whatever we want to implement, take everybody together from the day one. That, okay, I want to do this. What is your idea into it? And I think that is what will take us together. Take the nurse into system, take the guard into place, take that person into your team, take their opinion. Otherwise, things won't change. If you tell the guard, you have to do this, you have to change this, you have to do this, that's not going to work. Take their opinion. So I think engaging the stakeholders, I think this terminology, when it came from the partners, and I used to read somewhere in the papers, I never understood. But when I actually got down to doing things, I understood that engaging the stakeholders is actually very important. You have to take everybody together.
Right. Mr. Yogesh also has a question. How to avoid getting disheartened when your attempt to making changes vetoed by higher ups and you're the only one trying to change while others have accepted?
So I think we all have gone through that. And it is not that even now, I would have that Dr. Manju, look at your QI types, that kind of thing. It does go. So I think you just continue doing it, and you have your own, share of pleasures and your own share of sorrows. And pleasures are always more than the disheartening events. But you have to keep your moral up and continue doing small things. So that keeps you pepped up. So
and I would also like to say here that you will hear 10 things will go right and one thing will go wrong, and people will say, "Ye hai tumhara QI." So be prepared to hear all that. So essentially, when we are trying to do something, there will always be detractors. So whatever we do, we have to be strong about it, because eventually what we see is a system improvement, and we have witnessed it. So we have to be prepared, we have to be strong, we have to have a positive frame of mind, because we believe in it. And if you believe in it anyways, it won't stop.
No, and you must have buddies. You should have 2 or 3 people who can keep kind of encouraging you. So it is not you alone. I'm sure you get like-minded people. So I think that is what keeps you going. Yeah.
So, I mean, if I may just butt in. So, Yogesh, there will be things that you can do which doesn't involve higher ups. What is your specialty, if I may ask, Yogesh?
Physiology, madam. Physiology.
Physiology.
Hello? Yeah.
Yeah.
Yeah. So there will be something that happens inside your lab on which the higher ups need not be pulled in. It may just involve your students or postgraduates or your lab assistant. I'm sure there will be something that you can do at that level where the higher ups don't enter the picture at all. I mean, this is my 2 cents. Sorry to butt in. But yeah, rather than getting disheartened, I think that would be the way to go. Ajay has a question. Does the M&M meeting have any role to play in QI?
Is it maternal near miss meeting?
No, I think morbidity and mortality meeting, which the whole hospital has, right? I think that's what.
Yeah, no, in our department, we have done a QI on reducing intrapartum stillbirths. So I'm sure that you have, it is not that you can change the whole statistics, but out of that meeting, some action points emerge. So those action points can be taken as QI. That is what we did. When we did the stillbirth reduction, so we found that people were not making, not charting the labor progress well. So we made a single chart where the consultant also entered and the PGs also entered. So initially, they would enter everything at the last moment. So we said, let everyone enter in that same chart so that no entries can be done at a later stage, something as small as that. And then, introducing one ultrasound at 36 weeks to identify people who had growth restriction. 2 small changes and we could make a change in the stillbirth rate. So you get actionable point from the meetings which you conduct. So you find out these are the points where we need to make a change, and out of them you prioritize and pick up which one is optimum.
So Dr. Ajay Sharma, is that what you wanted to talk about, or did you mean something else?
Yeah, I got my reply, madam. Dr. Vidya, I got my
Yeah.
reply. It is amazing, the quality of work which is really being done. It is amazing.
So if anyone else has any questions, please feel free to raise your hand or to, even unmute yourself and speak. We are fine with that. Yeah, Aparna and Dr. Manju, if you had something that you couldn't cover because of lack of time, please go ahead now. We have some time.
I just wanted to add the economics of QI. We had done the similar project, Dr. Aparna and Dr. Manju, on surgical site on using this antibiotic prophylaxis. Don't tell this to my cardiovascular thoracic surgeon when you meet him. So there was one unit which used to give meropenem, vanco, and amikacin. And we kept saying why. And he says that I cannot risk because all of the patients who comes are VIPs and ejection fraction 25%, and it's improper not to sort of give. And he felt that surgical site infection would go down, and we kept tracking it. Fortunately, we got another cardiovascular thoracic surgeon who was evidence-based. He just used cefuroxime, and his surgical site infection was close to 0 SSI. And the economics between the two of them was close to 1.2 CR. Imagine how much patient must have paid because of your ignorance or non-evidence-based practice or your myth. So these antibiotics to prophylaxis is a very, very low-hanging, good initiative. Breastfeeding is a fantastic initiative. Anemia, I think your contribution to the nation and to the society is immense through these QI initiatives.
Yeah, Dr. Manju and Dr. Sanjeev, we had a similar experience in our hospital. We were part of FOGSI chain, and which has a robust, antibiotic stewardship program, and same thing, one dose cefuroxime for most surgeries, and maybe a maximum of 24 hours or up to 48 hours for certain category of surgeries. So we were having, unfortunately, maximum problem with the obstetrics and gynecology and some other specialties. So like Dr. Sanjeev Singh, we got an orthopedic surgeon who started using just cefuroxime for single sitting bilateral total knee replacement, one dose on the table and then one after 12 hours, and that's it. So that was a big game changer when in the monthly morbidity mortality meeting or in the infection control meeting, when this data was presented, that implant surgery is being done with 2 doses of antibiotic. Then with the same OT, we didn't have any special OT for the orthopedics, same OT, same environment, same instrument, same system, everything. Then why would you think that a cesarean section would get infected? So like that, if we get a champion, our job becomes very much easy to implement protocols. So I just wanted to share that. Radhakrishna, you have your camera on. Do you want to say something?
Ian, I have a couple of questions before I make my comment. Actually, I want Dr. Puri and Dr. Aparna being game changers. What warm has gone into their brains to think of working in QI, and what pleasure did it give them? Question one.
So if you ask me, I think it's easy for me. It is Aparna who motivated me because she called me for a workshop in AIMS. And she said that, there are other specialty people, it was basically the pediatricians who were doing it. So she asked me, ma'am, that in case we could do it, your people are going to, the obstetricians are going to listen more to us rather than anyone else coming and telling them. So, that is what started. And when I did my first thing, and I thought it was really very, very effective tool. But what is important is that I cannot do all the QI in my department. I need to have clones. I need to have people who will be the leaders. So I can't be the captain of the team, every team. So every team should have a different captain so that different people get motivated and they get that empowerment. So I think that is what is more important. And then once you start, imagine those patients who were lying on the trolley for 3 hours, 2 hours. Every day I used to see, every HOD would go in and would call the person who had done the cesarean, give them a firing. Why is the patient here? Then give them a firing to the sister. Why is it that the patient is there? There were no beds. It was such an integrated thing. The only thing, we made lots of changes, and ultimately all the patients would go on the bed within 10 minutes. Imagine how much of pleasure one gets out of it. And everyone was so comfortable. No done, nothing. So I think that is what keeps you going. So that is what is from my side. Aparna, you can add on your aspect of it.
Dr. Radhakrishnan, I think you asked a very cute question, I would say. But I think, yes, I mean, I was really fortunate that, I traveled in a flight back with a very, very senior and motivated neonatologist, Professor Ashok Devrari, whom I owe my QI journey to. But yes, he's a very brilliant person, and he's very motivated. Over the years, I have realized that, we have a huge vacuum of people who can connect policymakers to clinicians, because policymakers do not know what the clinicians need, and the clinicians they do not understand management, because as doctors we have not been trained in management. So basically we need people who have the intention and time to do management, and the policymakers need clinicians to help them. So I think the mixture of these two was something that I think we really got motivated together. And I was fortunate that me and Manju Puri ma'am worked together in one institute for 6 months, so we got to know each other well, and finally we started that. I think we kind of worked together and gelled together, and we are happy to be working together.
My second question would be that why OBGYN, why pediatrics, why isn't seen in other specialties? This is it that it's possible to do in these areas? And a second question will be, both of you are heading the more busiest departments in the country. How did you have time, or is it that you gave thesis topics to your postgraduates and finally got interested and got involved? Where is the time? I've seen Professor OBGYN in AIMS has no time to breathe, leave alone to work on QI.
So first of all, ma'am, may I?
Yeah, please.
So the first question I would say, sir, it is not limited to OBGYN and neonatology. The POCI model that we developed was developed in association. So as during the development, I was involved. I was the obstetrician, then the neonatology. The case studies which are incorporated into that model is OBS and neonatology, because it was developed as a part of that. But in AIMS itself, there are 12 departments which are doing POCI within AIMS itself. So essentially it is cross-cutting. Any department, any emergency medicine has utilized it, orthopedic. So everywhere POCI can be used. So it is cross-cutting. Regarding the second question regarding, why as obstetrician, I particularly feel that we feel the need. Being busy is also because it may be that, we need to be more organized. And POCI makes us more organized. Quality improvement can make us more organized. So if there is a need, I think we can work. That is my take on it.
Dr. Manju, would you like?
Yeah.
Sorry.
So as far as I am concerned, I feel that Aparna is absolutely right when she says that OB-GYN is the most disorganized, department. And there are so many emergencies. Nothing is in place. Everyone keeps on cribbing and fighting with each other. So I think the need was more perceived by us. And because we are in close connect with the neonatologist, they started practicing it. And that is how we came into the picture. And we thought we could, help it. And for me, I thought that, I started practicing it when I was not the head of the department. And in COVID time, I took over as head of the department. And believe me, it is this only which helped me out. It helped me sailing and settling everything in order, to the extent that I did a QI on how to have people circulating, because so many people would take leaves. And, if they were sick, they would not come back to the hospital. So that helped me. There were so many QIs which I did. and it helped me kind of organize the things better. And in case the head of the department does it, it does percolate much faster. That is also one thing which is there, but it is not essential that the head of the department has to be QI champion. I'm to say anyone can start it anywhere. And as NARCHI president, I felt that, you know, all our programs which are done in the are going to the community are not implemented. So we started empowering the ASHA workers and the ANMs and try to understand as to why are they not working. So we thought that we can make a difference in case we go take a bottom-up approach rather than a top-bottom approach. So I think that is how it went on. Thank you so much.
My next question will be, whatever you've done in terms of QA is something to do with patient outcomes, treatment outcomes. Did you do anything to save the money so that the administration also sort of pitched in and helped you?
Not as far as I am concerned, we have not yet
from a
looked up at
government
that
level.
angle. Yeah.
No, I think the government will, I think the systems will come in only when you are
Absolutely.
trying to
Yes.
save money for the institution. I mean, I think that's also a good
Absolutely.
possibility, really.
I
And
fully
my
agree with you. Yeah.
final question is, did you make enemies in the process?
No. At least I don't think so. I have made more friends, no enemies, but of course, a lot of people who would criticize what I'm doing and say that what QI. And even if now it is not that all the, the projects, they don't get derailed. They do get derailed in the middle. We have to bring them up. It is not that once a thing is fixed up, it stays the same. You know, it gets derailed faster than what you had made a change. So you have to be always vigilant and talk about that indicator every time and remind everyone that that is what is happening. You know, so that is what is the truth. Aparna, over to you.
No,
Um,
I would not say enemies, but I think there would be roadblocks. I think there would be anybody who's trying to change the system, they would be faced with a roadblock. And I would say that you get stereotyped in saying that, okay, this person is going to be in a certain way. And you would be facing that kind of a, prejudice. But eventually people do understand and they fall into place. That you don't just give up.
The Vidya, Dr. Babji will come in for a
Can-
minute.
Yeah,
Babji is the Vice Chancellor of Health University, Andhra Pradesh.
thank you for giving me this opportunity. The quality improvement is a way of life. It is everybody's responsibility. It's never an accident. It's a wonderful comment. And Dr. Radhakrishna was telling, why only gynec and neonatology? I was just thinking, why not in our university? See, there are lots of problems. The way Dr. Aparna and Dr. Manjula told, I was really amazed. And really, thanks to Radhakrishna for making me to join into this. I was just thinking, identify the problem. That is the first step they have said. Maybe Monday itself, I will call all my unit heads and sit in the departments. See, there are no fellows without problems. So why only medical departments? In an administrative university itself, we have lots of problems. And the quality improvement definitely can be sorted out. And definitely this presentation, if I can receive that, definitely those steps I was trying to note down, but it was too fast. I could not write all the steps. Definitely, I will try to follow it, and definitely with the quality of care from our university, we'll try to improve. Definitely.
I'll post this video to you, sir, so that you can go through it. Yeah.
So, Dr. Aparna and Dr. Manju Puri, if you don't mind, perhaps you could just share your slide deck also so that we can pass it on to.
No, that is fine, Dr. Vidya. But I would suggest everyone to go type POCQI on the web, on the link, Google link, and you will get access to both the modules. So please go through the modules yourself before you can call everyone, and you can even generate a certificate. Aparna, yes, you were saying something?
I have put it. So if you just go to this website, you can download the resources and it's available in the PDF format, and it's also available in the PPT format. So you can just download the learning resources and you'll get all of the resources as PPTs.
And it is showing that the website is down, but you can still click onto the PDFs and the PPTs and get access to that.
Thank you so much. Both of you have lots of passion for improvement. And the word you said that everybody, most of them, we do not try to change. And it's a very important point. And once we change, definitely people will improve. And all of us as doctors, we need to adopt this quality of improvement. And quality assurance is definitely a thing which all of us must practice. Thank you so much. I will definitely join every week.
Thank you so much. You had your hand up. Did you want to say something, Preeti?
Yeah, thank you very much. I've been very engrossed in the discussion, and what I joined late. I'm sorry if I missed some of the important points, but the most important thing, what I understand about quality is that it is a change management, and change is a behavioral change. It's very hard to achieve because how to get it down to everyone is hard. You can do it on a short-term basis, but eventually it wears out and people go to their old ways to resort things. That's how they do it. So change is the most important thing is sustainability. So you have to sustain it. The other thing which I wanted to, I don't know if you've discussed this already, is the psychological safety. So what is our threshold to mistakes? Because if in the organization we have I'm sorry. So if in the organization we have a low threshold for mistakes, people will not come up and own up to what they've done wrong, and for the fear of retribution or their own accountability. So I think it's very important in the department to maintain that psychological safety whereby anybody can come up and be safe to own up. And when you own up to what you've done wrong, you work on the process and not on the people. And I think that's what is very, very important. And in our medical curriculum, these two things are never taught to us. We're never taught, because as medicos, we're always taught to achieve, to be the best, to be perfect. But perfection is a continuous journey. So I think that is the most important part of quality improvement, I understand. I mean, that was just my thoughts on this.
Ravi, you have your hand up. Did you want to say something?
Yes, I was going to just say that based on experience from research, the thing that really helps is to have an independent quality department. So that people within the department don't fight with each other or identify people as that's the person who's enforcing all these impractical solutions and things like that. But I do want to emphasize that it is very, very important, even in the research aspect of things. I mean, quality in clinical trials. How do you reduce protocol deviations? What are the ways to handle issues that come up? These are extremely important, and every principle that was elucidated by Drs. Aparna and Manju apply not just to clinical care, but across the board quality improvement in anything. So just like people, we heard about how it could be applied to departments in a university, it can be applied anywhere. So certainly, it's another area to think about in research, and also have a separate, sort of quality group. There are two aspects. There's quality assurance, and then there is, quality improvement, and they both work hand in hand to make sure that the quality of the work, whether it be research, whether it be clinical care, whether it be anything else, teaching, is maintained at a level that is acceptable.
Thank you. We are kind of almost out of time. Dr. Manju, any closing comments?
Ma'am, I want to say one thing. Thank you, Babji sir, for arranging this link in a RMC group. I belong to RMC. Rukmini sir. Rukmini, Ravi Mrs. Thank you so much. It's really love to hear these beautiful speeches. I'm really encouraged, so motivated. Thank you so much, ma'ams. You are both are fantastic pair. Thank you.
So I think I thank everyone for their
Belong to
participation. And I guess that let's all be the change makers and try it in small ways and share our experiences. Dr. Vidya, thanks for organizing such interesting meets on Thursday, and wherein we get to share our ideas and share our experiences. Thank you so much.
Thank you, ma'am. Dr. Sangeeta, you have your camera on. Did you want to say something? Yeah. You're muted. Sangeeta, you're muted.
Yeah.
Yeah.
So after joining that group of decreasing the cesarean section rate, I've tried to attempt that POCQI multiple times, but it somehow stops at 97% and then says I have to go back again, and till date I am not able to collect my
So,
certificate.
Dr. Sangeeta,
I don't know where it's going wrong.
So, Dr. Sangeeta, the virtual platform for certificate generation is currently not working. So, you will have to go through the POCI PPTs and the learning manual.
No, but
So-
it is online available, no?
No. So,
I've
the
attended-
virtual, yes. So, the virtual certificate generation is not happening now. So, you can't generate the
No,
certificate.
I attended last month or before that also.
Yes. So,
So
because
once it was done
I
with
tried.
Dr. Karen's this thing login ID, I did it from her husband's ID because I was not able to. She said, "I'll get a certificate."
So Sangeeta, if you don't mind, I'll put you in touch with one of somebody who can help you with your specific problem. I think we should kind of keep it to what is of importance to everyone. So Aparna, your closing comments, please.
Yeah, so I just like to thank you, ma'am, for having me here. And I think we had a great discussion. And just like to say that I think quality improvement is something that we cannot now manage without. So everybody should, as a policy, I think we have to kind of, move towards quality, and we should not shy away from quality as clinicians, because if we want the experience of care for our own patients to improve, we as clinicians should start thinking about quality in a more holistic way. So thank you very much for having us here today. It's been great.
Thank you, Aparna. Dr. Sanjeev, your closing comments, please.
Yeah, loved listening to you, Dr. Aparna and Dr. Manju. It was a fantastic evening, very inspiring, and the words which you had used, high intention, very sincere, intelligent direction, all are so apt, and the passion which you, with which you are driving this whole thing. Salute to you for doing such fantastic work in changing the society. We would love to hear more, and also love to have you in our facility at some point of time. We'll connect. But thank you, Dr. Vidya, for including me today evening.
Yeah, I must thank Dr. Punithar for putting me in touch with you. He's unfortunately in an oncology meeting, so he couldn't join in today. So thank you everybody for making it such an interactive session. Special thanks to Dr. Manju, Dr. Aparna, and Dr. Sanjeev for making time on a weekday. We'll see you again next week with another episode of Marvelous Medicine. Till then, take care and stay safe. Good night.
Thank you.
Thank you.